The next two presentations will be made by Dr. Kimani Ndungu. Kimani is a consultant, obstetrician, gynaecologist, and minimal access surgeon and quality director at Consolata Hospital Nkubu. His clinical and leadership work centers on quality improvement training and building evidence-based protocols for patients. He is the recipient of the 2026 Africa Healthcare Awards for Excellence in Surgical Specialties, organized by Zenith Global Health in Kigali, Rwanda. He is recognized for his contribution to surgical excellence and healthcare quality across the region. And I think you saw a sneak preview of him yesterday, discussing physiology. Today he's discussing real obstetrics and gynecology. Dr. Kimani.
Thank you, Kigondo, for the kind introduction. So I'll be discussing non-technical skills, briefly touching on the evidence and describing our institutional experience at Consolata Hospital Nkubu, where I serve as the OBGYN and quality director. So non-technical skills are the cognitive interpersonal skills that complement the technical skills that we know. And there are many of them, but the four main ones are situational awareness, communication and teamwork, decision making, and leadership. Now, evidence has shown that when you analyze adverse obstetric outcomes, about 70% of them involve non-technical skill failures. Yesterday, someone was talking about the confidential inquiries into maternal deaths, and what has been consistently identified, both in the West and even here, if you look at the 2017 confidential inquiry, is that things like communication failure, where there is inadequate sharing of critical patient information, poor team coordination, so the unclear roles and fragmented team response. Delayed escalation, I think, is quite important. Probably most of us would share instances where you're called in, but you're called in late. And situational awareness, failing to see what is happening. Now, there is a wealth of evidence, but I'm just going to identify three which are specific to obstetrics, which I found to be relevant. And the first one was an interesting one. This one was done in Denmark. And so what they did is they put video recorders in the labor room suites. And so they assessed how PPH was managed by looking at the video. And it was quite technologically advanced because the video was being activated when the OBGYN gets into the room. And they had a validated tool to assess specific non-technical skills. And they also had a tool to assess how this PPH was managed. Then the other thing they looked at was the risk of delayed transfer to theater for those that needed theater. And the results are quite interesting. They found that in about 83.7% of the teams that had high non-technical skills, they had a high clinical performance. Basically what this means is the teams that had good non-technical skills performed managed PPH appropriately based on the tool that they had looked at. And the converse was also true. Those that had less, 80% of those that had less non-technical skills did not manage PPH appropriately. And they also looked at the decision to, the risk of delayed transfer to theater, and they found that those with reduced non-technical skills took much longer. So what is the summary of this? Basically, this tells us that the emotive, the oxytocin, all those things are not enough. You need to also have that presence of mind to identify that maybe we need to escalate. This again was another interesting study. I think this was done, I can't remember where, I think it's in the States. And so this one, they looked at three groups. The first was a control group. The second was a group that went through the training, but it was didactic in terms of lectures, and they followed the team steps training. And the third one, they also embraced simulation, where they would have simulation So for example, if it's something like postpartum hemorrhage, they don't just discuss the 40s and oxytocin, but they also have a simulation, and they look at how the teams have managed, how they've behaved in terms of non-technical skills. And the results are quite interesting. The control group, there was no change. The outcome they're looking for is what was called the weighted adverse outcome score. The ones that had didactic, meaning just lectures, the change was very minimal, 1%. But those that had simulation and didactic had a reduction in 37.4%. So what does this tell us? This study told us that it is not just important just to do lectures, but also simulation-based training. And this is one of the best studies that talks about simulation-based training. Now, for the purists who say that RCTs are the gold standard, this is one RCT that was done, I think, in the States. Fairly robust. They looked at 15 hospitals, 28,000 deliveries, and the intervention was a training program. CRM is crew resource management, okay? Because most of these trainings are borrowed from the aviation industry, and the control was where there was no training. And they looked at an adverse outcome index, and they also looked at the decision to incision time. Now, the results showed that there was no difference in the adverse outcome index. Basically, what they showed was that whether the teams were trained in non-technical skills and those that were not, they could not identify a difference. But then you need to remember that this was a very heterogeneous population. The training duration was a short time, and in fact, it has been shown that for you to have effective impact, some studies have showed you may need to have regular training that goes on for up to 2 to 3 years. Then there are also issues like turnover of staff, which we also have experienced in our facilities. But the significant finding that they found was that the teams that had training in non-technical skills had a higher decision to incision time for emergency C-sections. So basically what this study told us is that while they did not demonstrate a difference in the adverse outcomes, the teams that had this training appeared to respond faster to emergencies. And this is the conceptual framework that made us think about our incisional practice, where if you look at poor non-technical skills may lead to error, causing an adverse event. So failure to escalate, postpartum hemorrhage is not recognized, then you have an adverse event. And so you go and analyze those events, and you identify the specific non-technical skills that could have contributed. Then you try to improve them and possibly see if you can avoid or capture error. And this was the context within which we thought about this in 2020. And why we started this was when we looked at the root cause analysis for things like postpartum hemorrhage, APH, asphyxia, we found that the biggest issues that we're identifying were communication breakdowns between clinical teams. For example, you have a postpartum hemorrhage, the intern comes or medical officer, draws the sample for blood, then later, 1 hour later, the lab has not gotten that sample, okay? So everybody knows that this patient needs blood. It was drawn, the sample, but because of that lack of communication. Delayed recognition of patient deterioration. A patient has postpartum hemorrhage, for example, and maybe a medical officer is performing a cesarean section and continues doing the same thing, all the while not appreciating that the patient's vitals are going down, and probably maybe you need to think of a next step. And also we found that there was suboptimal team coordination. Handovers were not structured. We were sharing with colleagues yesterday, the most dangerous times to go into a hospital is usually during the handover shift and the delayed escalation. And so that is when we thought about having this NTS program, because again we realized most of our training centers on the technical skills. Hardly do we talk about non-technical skills, which I think is something that in other jurisdictions people are also starting to think about. And so far we've trained 150, about more than 150. This includes medical officer, nurses, and the interns. And this is a brief snapshot of our curriculum. So the first thing that we look at is situational awareness. And situational awareness has 3 levels. you ask yourself, what is happening? So a patient is bleeding, we have PPH. The next question you ask yourself is, so what? So you look at the vitals, this blood pressure is going down, patient is going into shock. Then the next question is, what next? What are we going to do? And as I mentioned in the start, this is borrowed from the aviation industry. And if you look at that cartoon, a pilot flying and seeing clouds and seeing a goat. So situational awareness, the what is seeing that I'm flying and there's a goat. So the so what is saying that, wait a minute, what would a goat be doing in the clouds? So most likely, this is a mountain. So the what next is probably they need to pitch higher. And we had one case last week, which I'll briefly share as I talk about this, where a patient came in at 34 weeks with absent fetal heart rate and confirmed IUFD. And the ultrasound also showed a retroplacental clot, but patient had some pain and some bleeding, which the nurse described as heavy show. The nurse called the intern, and the intern was busy attending to other patients, and the intern said, since she's 3 centimeters dilated, IUFD, just allow labor. The nurse was not comfortable with this, and so the nurse called the second on call, the medical officer, who came and reviewed the patient and found that what was dubbed as heavy show was significant bleeding, took the patient for a cesarean section. Before taking the patient for the C-section, the medical officer informed the third on call that they're proceeding to theater, and that was the plan. Now, coming to our curriculum, situational awareness, the nurse who saw this patient demonstrated situational awareness when we did a debrief, because she saw that there is bleeding, there's an IUFD, ultrasound has shown a clot. Yes, the vitals are fine, but because of this pain, this could be an abruptio and probably needs urgent intervention. The intern lacked to have situational awareness, because when they were called, they thought that this patient is stable, this patient is not having significant bleeding, has an IUFD. The medical officer demonstrated situational awareness because, of course, he recognized that we need to intervene, and when they went in, actually found a huge retroplacental clot, and also had situational awareness, appreciating that he may go to theater, encounter a covaliar uterus, and probably need the third on call. So that's why he discussed this case with the third on call. And these are things that came up with when we did the debrief of this case. Now, the second item in our curriculum is communication and teamwork. And in communication and teamwork, I'll start with the last one, safety critical language, AID. So we train our doctors and nurses to use safety critical language in the sense that the first 10 seconds of a consult, I should know what you want. Do you need advice? Do you want to inform me? Or do you need me to come? Okay? So for example, when the medical officer was calling the third on call, the first statement was, I would like to appraise you of this case. Okay? If they need your advice, then they will say, I would need to get your consult. Then if they need you to come, if it's, for example, shoulder dystocia, you don't need to have a lot of stories. Then 2 minutes into the conversation, that's when you're saying shoulder dystocia. So the first call is, we need you in theater. We need you in labor ward, we have shoulder dystocia. This is actually evidence-based. It's actually been shown that it improves performance. So that's the first thing that we train our team. And the other thing is the first one, which is the SBAR, which is now a model that we employ in our handovers, where we start with the situation, the background, assessment, and recommendation. When we did an analysis, a debrief of this case that I've talked about, we found that the nurse, when the nurse was consulting with the medical officer in turn, the communication did not follow the proper SBAR format. Because in our SBAR format, we stress that you should first start with the situation. Within the first 30 seconds, we need to know what you're thinking. So I have this patient with an IUFD, I'm suspecting an abruptio. Then now you go to the background, give your story, the assessment, then the recommendation. The other thing also on communication that we train our teams, is on closed loop communication, where if you give a message, the person receiving it repeats it, and the sender confirms it. So for example, in theater, if you need the anesthetist to administer oxytocin, so you say, please administer 10 units of oxytocin. You don't need to look at the anesthetist. The anesthetist says, administering 10 units of oxytocin. Then you respond that, you acknowledge that the message has gotten there. This took quite a bit of time. And so what we used to do is the sender used to repeat the message. So I say 10 units of oxytocin. So if the anesthetist is giving it, if I don't hear a response, I repeat the same. And so, so that now people learn how to use this closed loop communication. And the last one is the third one I've indicated there, where we have directed communication, where tasks are assigned by name and specific individuals. This came from a root cause analysis we had of a case a few years back of postpartum hemorrhage, where we found that there was a delay in blood transfusion, and the issue was there was no proper directed communication. The lab samples were drawn and they were placed there. Then nobody took them to the lab. The next one is decision making, and decision making in our training we emphasize on the 4 steps, where the first step is you assess the situation. In this case, the nurse assessed and thought that this patient has an IUFD, retroplacental clot, some pain, what they thought was heavy show, but this could be an abrupt show. Then what are the options? Maybe I need to consult. So this nurse consulted with the intern, then assessed to see if that was the appropriate response. When she found that it wasn't, she escalated to the second on call. And the third one, the last one is leadership, where in our curriculum we train on 3 domains. The first one is protocols. So in our unit, we have developed protocols for, I say that the good thing with obstetrics is that our emergencies, you can count them, especially the most common ones. So we have protocols for all our emergencies, and we make sure that all our teams are trained. We have a file, a laminated one, and we also have a file. So if a new intern is coming or a new nurse is coming, she has to go through this. Then also, on top of the protocols, based on past experiences, there are certain other policies that we've put in place. For example, we realized that antepartum hemorrhage was being missed sometimes, being labeled heavy show. And so one of the things that we now stressed, which usually happens, is that there's no diagnosis like heavy show. So it's either it's show or there's bleeding, because you'd rather come and assess and find that it is not significant. We also would give feedback and constructive feedback, where we give feedback to teams, when they've handled a case. An example is, just yesterday, I got a call from members of my team debriefing me about a case of shoulder dystocia, which was managed by one of the nurses, and the outcome was good. And after that, we made a call now to this nurse to, acknowledge that well done for what she did, and so this also helps to motivate them. The other significant thing is the third point there in supporting others, flattened hierarchy. Basically, what we stress on is that we have a flattened hierarchy. It doesn't have to be nurse calls intern, intern calls medical officer calls consultant. And when we did a debrief of this case, we found that our nurse actually obeyed the flattened hierarchy, because when she didn't get what she thought was the best plan from the intern, instead of just writing there in the KOGS or in the file that intern said monitor labor, she went ahead and called the second on call. Then in terms of coping with pressure, we train on taking responsibility during emergencies. And the other thing which we found to be quite useful is we always do a debrief whenever we have a case. Just this morning, I got a call about a patient who's just been delivered this morning, came in with antepartum hemorrhage, and they went in and found a retroplacental clot and abrupt show. And when they were calling me, the medical officer and the nurses were now doing a debrief. So they're looking at the case, what time did this patient come, what are our timelines, how did we perform? And so next week, when now we go back, now we'll be doing an assessment, and that is how we've been able to see how we've been able to improve in some of the outcomes. The other thing, sorry, I forgot to mention, that we've stressed on also is on the issue about time. We found that we were wasting a lot of time. For example, when we have an emergency C-section, there's a lot of time that is being wasted without you realizing it. You go to theater, by the time you look at your theater notes, it's been 1 hour, and you're wondering what happened. So what we did is now, usually when a decision is made for a C-section, for example, the first thing that the doctor does is they look at the watch, and they have to indicate in the file that decision time is this. Then when they perform the C-section, after the baby is out, they need to document what is the decision to delivery interval. And so all our files, all our cesarean sections usually would have that. The other thing that we did is we now use categorization, because we found that emergency C-section is a bit ambiguous. So we have category 1, category 2, category 3, category 4. And so we're able to even do audits, and we look and see that what is the decision to delivery interval for all our cases. And as I'll be sharing, this is one of the things that we've been able to see an improvement in. So in summary, this is a snapshot of the NTS program in our facility. So we usually do simulation-based trainings where we sit down and do training, for example, on say, postpartum hemorrhage. And in that training, we're doing simulation with mannequins and all, but we're also focusing on the non-technical skills. We also do NTS workshops. So we usually do this every rotation for the interns, we do this. Then for the nurses, we do it quarterly. Our handovers, we use an SBAR format. So during the handovers, when our interns are presenting, medical officers are presenting, that is one of the things that we keep stressing on. The other thing that we introduced a tool called the daily safety huddle. So every day during shift handovers, the teams, the nurses, go through what's called a daily safety huddle. And basically, this is just giving a snapshot that we've handed over the ward. We have one patient of concern, maybe a patient with preeclampsia with severe features. Then we also do workplace observation, where we give feedback. And we've borrowed, the tool that I use is, if you look at the RCOG, they have a non-technical skills training evaluation tool. And that's what we use, so that when we sit down with the intern, the medical officer, we're able to give them feedback. And we do refresher cycles every 6 months. That is a snapshot of the tool that we use in our facility. And so basically, this takes 5 minutes. They've done the handover of the specific patients. Then now they look and see what are the critical events. So for example, they'll say that we had, like now when my team now is handing over, the team that was at night to the team during the day today, in that handover, they've handed over that we've just delivered a mom with a abruptio and is on transfusion, etc. What are the at-risk patients? So if maybe a mother is in labor and she has a huge BMI, diabetes, risk of shoulder dystocia. So this we found helps because the team now will be thinking about it. Equipment, if equipment is malfunctioning. So the other thing that is usually handed over is equipment, so that we don't get a postpartum hemorrhage, then the BP machine does not have batteries or something like that. And we've done an analysis of our results, and that's a snapshot of our results. So this is, training programs are assessed on something called the Kirkpatrick Framework. This is the framework that is used for assessing training programs. And basically it asks 4 questions. Did the guys you're training value the training? Was it useful? And I think even some of the presentations made yesterday, I think by Prof, that's one of the things we're talking about. Then did they actually gain any knowledge or skills? And did this impact their behavior? And overall, what were the patient outcomes? And when we looked at this, the first question, when we started this program in 2020, we did a survey, and we found that 96% actually expressed satisfaction. We usually do exit surveys for all our interns, and one of the things that they've always consistently said that they valued from the training was the focus on non-technical skills. And they said that they feel more confident. We've also been able to notice that there is improved NTS performance. That means that cases where situational awareness, communication, leadership, we're actually seeing an improvement in that. And SBA is now routine. The other thing is the safety huddle that I've just shared. So our quality office usually does monthly audits and to see the compliance. And this was for the month of February, 94%. Basically, this means that we look at all the days of the week. How many days was this done? And the evidence that we use for this is once this form is filled, usually it is collected. Then we're able to look and see how many days that this was done. The other thing that was now is fully entrenched, which we are quite happy with, is a WHO patient safety checklist. And so that is 100%. So there is no patient who's having any surgery, whether obstetric or any other, that the WHO patient safety checklist is not looked at. The challenge with these non-technical skills is that it is hard to link it to outcomes. Okay, it is hard, even if you look at the literature. But what we found, at least when looking at the data, is we did an audit of 118 patients, and our decision to delivery interval went from 14 to 16 minutes. Okay, and there was no new intervention. We didn't get faster trolleys, or people weren't running faster, but it's just having that situational awareness. And the game changer for us for this, which I would propose for colleagues to consider, is having documentation of decision to delivery interval for all cases, because this helps you reflect, and then you see where it is that you may be having time being wasted. It's certainly not been a walk in the park. We've had some challenges. Turnover is one of the biggest issues, especially with the nurses. Sometimes there's a time we had a crisis. We had very good nurses, I'd taken them through sessions. We've done a refresher, 6 months, and very good. Then all of a sudden, the county advertised for jobs, and we had like 6 of them leaving. And now I have fresh nurses. But I guess we have to contend with that. And so what we do is we do regular trainings. Of course, competing clinical workload also becomes a challenge. And so what we've done is that through the management, we try to make sure that these training programs are not eating into their personal time. So we don't ask them, for example, to come early. We see if the rota can be arranged so that it is during their work hours. So even if we need to get other people to come work so that everybody can be trained. Then we also have a log of who is trained. So we don't just say today we are doing a training. So I can tell you that the nurses, this one has attended this training, this one and that one. Changing culture is difficult. It takes time. The WHO patient safety checklist I've talked about, they're 100% we are at right now. But it's taken, God knows, 2-3 years, okay? Because changing culture takes time, and I think it needs some bit of patience. And faculty development, people who are actually training this. So when he started this, I'm the one who was driving this and conducting all this, but then I realized that I'm not able to reach everybody. And so what we've done is that we've tried specific aspects to see if can be trained by other people. So for example, if an intern is consulting with a medical officer, the medical officer makes sure that gives feedback to the intern if they follow the SBA format. And that way, we found that there's been improvement in the trainings. So in summary, the non-technical skills that we, from our experience, have found to be important are situational awareness, knowing what is happening, asking yourself what next, communication and teamwork, decision-making, and leadership. And we know from evidence that loss of these non-technical skills leads to harm, things like delayed escalations, failure to recognize deterioration, and poor coordination. And so my proposal is let us see the aspects of non-technical skills that we can embed into our training, so that when we are training people on postpartum hemorrhage, for example, it goes beyond emotive and the 40s. It goes beyond that. And that is the team that we work with. In fact, I took this photo when we were doing the debrief of the case I've talked about. Because after that case, we sat down, did a debrief, and the debrief that we do it's not punitive to ask the nurse or the intern you know, why didn't you take this patient for a C-section? We found that to be counterproductive. And so through this, we found that cumulatively, people become better and better. Yeah, otherwise, I think that's the end of my presentation. Thank you very much.